multidisciplinary. We've got to identify it. Johanna, maybe talk a little bit about sort of strategy. Do you give pre-op chemo, pros and cons to that? Let's at least get us to surgery. So surgery right away versus pre-op chemo.
You know, debate, and there's no wrong answer here. So the question is, if you've got somebody who you could, and I hate using this word, but one of my mentors used to use it as a chip shot surgery with the liver disease, where it's very quick to get that tumor out. It's small enough. You think the cure rate's going to be good. I'll send those patients oftentimes to surgery right away. The issue becomes more of, is it helpful to know that your tumor responds to chemotherapy before you take them to the operating room, so adjuvantly you sort of know what you're doing? And I think that there's some benefit to that as well. But I think also there's the issue that you could shrink the tumor so much that you can't find it anymore. And we've all had those patients where we did so well that we had to wait for the tumor to grow back. And there's nothing that's more stressful on a patient than knowing they've had this potentially curable disease and you're waiting for their tumor to grow. And I think that if it's a very easy surgery, for me personally, I'll just go ahead and have them take it out. But otherwise, I'll use very little pre-op chemotherapy, only about 2 months worth before I restage them and get into the operating room.
Tony, PET scans, fancy MRIs to make sure you're seeing all the little stuff that you can see?
So I think for MRIs, we do use MRIs with EOVIST specifically, and that actually provides the surgeon with what they need to look at for resectability.
So they're starting to learn this too. So,
Yes.
you know, not just a regular outside CT, they want the best imaging.
They want the best
so that we can find those little ditzels, right?
Yes,
Okay,
absolutely. And you have to have a good mapping of the liver. No, the PET scan, you know, role is controversial. I actually tend to favor doing it just to rule out any other metastatic disease that you
1 centimeter warm mediastinal lymph node. You're going to operate on the patient?
This is where you use your clinical judgment. But you know, oftentimes there had been studies in the past that did suggest that you ultimately have about 20% of the patients would essentially avoid unnecessary surgery. Probably is less than that, frankly. But I think the most important, so PET scan is really not as important. You use it judiciously. But the most important is to get a good mapping of the liver and a good view. And an MRI with EOVIST will probably make the most sense.
We may not agree on this. Pre-op biologics.
So, one other word about the PET scan. One thing I would say is the PET CT scan, which is often a community test, in general is a useless test because it's almost always done without IV contrast for the CT. So you get a meaningless CT scan, which really doesn't help us. And one of our struggles always is getting the insurance to agree to do a subsequent scan, which is what we really need to make the right decision. In terms of biologics, well, the issue of the EGFR antibodies has been looked at, and in fact, in the classic study, Neoadjuvant, showed no benefit, in fact, detriment to EGFR antibodies.
Makes no sense either, right?
Unless they had all right-sided patients in their group.
But they had a good response, right?
They did.
Good response, good resection.
So that is contrary to common sense. I personally, if I have a patient who is resectable at the get-go, but I've elected to do, I agree with Johanna, 4 cycles of upfront chemotherapy, I do not use a biologic. And the reason is, if the risk is 1 in 25 that there'll be a major complication to bevacizumab, for example, if your patient has a stroke or has some major event, you may miss the opportunity to cure them. Bevacizumab, it's not as if it changes the course of the disease that dramatically in 4 cycles. So I typically do not use a biologic if I believe a patient really is curable right off the bat. If you need a mega response, if you need really to have, if you think it's going to take more than 4 cycles, I may very well use a biologic.
Mega response needed. What am I giving? What do you want to give?
Mega response needed, probably FOLFOXIRI, and I'd do Bev.
I would do Bev in that situation.
Although
too,
if you look at TRIBE, right, FOLFOXIRI Bev did not increase the likelihood of R0 resection of liver metastases, so at least in their analysis. But I agree with you. In fact, it is, in our experience, I've yet to see a patient who didn't respond to FOLFOXIRI. It is incredibly active chemotherapy. And so I do think we're using much more of that than we used to in the past.
Everybody okay with that? So decision making based on the patient in front of you, avoid the risk, you want to see a response. But let's go back to that case. I think this is the hardest patient.
Great.
But you set it up. So the patient, at their surgery, they find a 1 centimeter liver lesion and they remove it. And so they now come to you. Stage 4, no evidence of disease. Let me make it 10 positive lymph nodes.
Oh.
Yeah. So, and this one liver lesion, what's the post-op therapy?
6 months of FOLFOX.
So just straight adjuvant.
Yes.
Biologic in this setting?
No.
Tony?
No biologic.
Okay. High risk though. This patient's in some trouble, right? And just the role of adjuvant therapy. Magic's 6 months. Is there really? Do I have to give 6 months?
You do until proven otherwise.
Really?
And we will have whether
I'm
you
not
can
going to say
extrapolate
no.
to the stage 4 NED patient is a question, but we expect in the next month or two to have the results of a pooled analysis of 7 studies looking at 12 versus 6 cycles of FOLFOX in the adjuvant setting. If those are not different, then I think 6 cycles might be enough for the stage 3 patient. Whether that applies for the stage 4 NED patient, I don't know.
Okay, yeah, go ahead, Tony.
So, in fact, I would actually argue for less in this particular patient because it's almost 100% risk of recurrence. I would say, you know, I'd frankly, you can argue that no chemotherapy is also acceptable. And so a 3-month FOLFOX or even a straight 5-FU or capecitabine would be just fine.
I got an email just last week of a patient, some doc asking me, patient had adjuvant therapy a year and a half ago, now has an isolated liver lesion that's been removed. Anybody given like FOLFIRI for the heck of it?
So that's a good question. That's also a guess. I think if you're a year and a half or so out, I probably wouldn't. 6 months or 3 months, I might. But
Adjuvant FOLFIRI?
I probably would do neoadjuvant FOLFIRI in that case. But I think the answer is, of course, FOLFIRI has been looked at in numerous studies. Does not work as
Doesn't
an
have
adjuvant.
an adjuvant effect, right?
Correct.
Others thought leave them alone, just surgery?
I'd leave them. I'd leave this patient alone, or as you know, Alan said, you know, depending on the situation, maybe treat them as metastatic disease for a limited amount of time. But my gut feeling would be for this patient just to observe.
Any different?
Year and a half out, if the patient pushed for it, I might try some adjuvant therapy, but be quick to DC it if you have any toxicity from it.